Hello friends, welcome to second and last lecture on endocarditis. In previous lecture, we have seen that endocarditis is classified mainly as non-infective and infective types. So, in previous lecture, we have already studied rheumatic endocarditis, typical verrucous endocarditis and non-bacterial thrombotic endocarditis. So, all these three types come under non-infective endocarditis, and in this lecture we will look at infective types. So, basically there are infective types are classified as bacterial and other infective types other than bacterial. So, let us continue. So, what is bacterial endocarditis? Bacterial endocarditis is actually an infection of valvular or mural endocardium. So, again endocardium covers heart valves and heart wall. So, if bacteria affect valve, then it will be called as valvular endocarditis, bacterial valvular endocarditis, and they may affect heart wall. So, it can affect both wall and wall. And one characteristic feature of bacterial endocarditis is that its vegetations are typically friable and infected. So, infected it is a surety because it is bacterial endocarditis. What is the meaning of friable? Friable means the thing which is easy to break, which requires very less force to break it, that is called as friable. So, bacterial endocarditis, there is vegetation in other forms of endocarditis also, which is called as verrucae or vegetation or growth or whatever you can say. But in bacterial endocarditis, this growth or verrucae or vegetation is very friable, so it breaks very easily, and it is more common in old age and males. So, further, bacterial endocarditis has two clinical forms. It has two clinical forms. What are clinical forms? That means it manifests as in two forms. One is less aggressive and another one is more aggressive. So, what are its two clinical forms? Number one is acute bacterial endocarditis and second one is subacute bacterial endocarditis. Now, coming to first clinical form, that is acute bacterial endocarditis, it is more destructive type. It is more destructive type and it occurs in previously normal heart, and it has a rapid fatal course of 2 to 6 weeks. So, it is it is more aggressive type. Acute bacterial endocarditis is more aggressive than subacute type, and in 2 to 6 weeks from being infected, a person can die if proper treatment is not given. So, only in 2 to 6 weeks from infection to death occurs. Second form is subacute bacterial endocarditis. It is less destructive type and it occurs in previously diseased heart. So, this differentiation is important. You have to remember that acute bacterial endocarditis occurs in previously healthy heart and subacute bacterial endocarditis occurs in previously diseased heart. And this type is also called as endocarditis lenta. Lenta means slow. Because it is not that much aggressive, it is called as endocarditis lenta. Now, coming to predisposing factors, these predisposing factors are common for both forms. There are basically three predisposing factors. First one is conditions causing bacteremia, septicemia and pymia. That is, these conditions are caused by infections somewhere in the body or surgery, etc. These three terms, bacteremia, septicemia and pymia, looks very similar, but there are minor differences among them. Bacteremia is simply presence of bacteria in the blood. Septicemia is presence and multiplication of bacteria in the blood. So, in bacteremia there was only presence of bacteria in the blood, and in septicemia there bacteria are not only present but they are replicating. That means septicemia is proper infection of the blood. In bacteremia there are only some bacteria are there present in the blood and they are removed by body's natural defense, but in septicemia they are replicating and increasing in number. So it is basically a type of blood, it is a basically blood infection, or it is also called as blood poisoning. And third one is pyemia. So pyemia is also presence of bacteria in the blood, but they are pus forming bacteria. And if pus forming bacteria are flowing with the blood, obviously they will lodge some in on some organs of the body, and they will form pus at multiple spots in the body. So if a person is having bacteremia, septicemia or pyemia, then he will have chances of increased chances of having bacterial endocarditis. It is very obvious because bacteria are present in the blood, and with circulation they will also go to heart, and they can cause endocarditis. Second predisposing factor is underlying heart disease, like chronic rheumatic valvular disease, ventricular septal defect, or subaortic stenosis, etc. And last, third predisposing factor is impaired host defenses, like in lymphoma, in leukemia, in cytotoxic therapy, like that is given in cancer, or deficient functioning of neutrophils and macrophages, because neutrophils and macrophages are working in body defense. So if they are not functioning normally, the host defense will be impaired, and it will allow bacteria to infect the organ. Now coming to clinical features. So clinical features can be divided, can be studied according to acute type and subacute type. So in acute type there will be high grade fever, chills, malaise and weakness, and in subacute type there will be slight fever. Fever is lesser in subacute type, and there will be fatigue, loss of weight and flu like symptoms. In acute type there is a term called malaise. So what is malaise? It is unpleasant feeling, or feeling of weakness, you can say. Now coming to complication and sequelae of bacterial endocarditis. So these complications are divided into cardiac complications and extracardiac complications. Cardiac complications are those that affect heart, and extracardiac that affect other organs. So what are cardiac complications of the bacterial endocarditis? They are valvular stenosis or insufficiency, perforation, rupture and aneurysm of valve leaflets, abscess in the valve ring, myocardial abscesses, suppurative pericarditis and cardiac failure from one or more of the foregoing complications. That means all these complications may result in cardiac failure. Now coming to extracardiac complications, there may be embolism, because in the start of lecture I have told you that the vegetation in bacterial endocarditis are very friable, that is very easy to break. So sometimes they break from endocardium and flow with the blood and may cause embolism. Second extracardiac complication is petechiae, and then Osler's nodes and Genevieve's spots. Osler's nodes are found in subacute bacterial endocarditis, and Genevieve's spots are found in acute bacterial endocarditis. What are Osler's nodes? They are painful, tender nodules on the fingertips of the hands. And what are Genevieve's spots? They are painless. Osler's nodes are painful, and Genevieve's spots are painless, and they are non-tender also. Osler's nodes were tender, and Genevieve's spots are non-tender. Painless, non-tender subcutaneous maculopapular lesions on the pulp of the fingers. These are Genevieve's spots, and they are found in acute type. Last extracardiac complication is focal necrotizing glomerulonephritis. So here is a image of Osler's node and Genevieve's lesion. You can see the image on left is Osler's node, and the image on right is Genevieve's lesion. Now there are some distinguishing features of acute and subacute bacterial endocarditis. Just read once. Duration is less than 6 weeks in acute form, in more than 6 weeks in subacute form. Most common organisms Staphylococcus aureus and beta streptococci in acute form, and Streptococcus viridans in subacute form. Virulence of organism is high in acute and less virulent in subacute form. Previous condition of walls, as I already have mentioned that in acute form they are previously normal and in subacute form they are previously damaged. Lesions on walls are invasive, destructive and suppurative in acute form and usually not invasive or suppurative in subacute form. And clinical features in acute form are features of acute systemic infections, and in subacute form there are splenomegaly, clumping of fingers and petechiae. Now there is one more table which shows distinguishing features of vegetations in all forms of endocarditis. You can read this. You can read and just if you think anything is important, then you can note it down. I will give you 2 minutes. Just when you are watching the video, pause the video and read it, and if you think anything is important, you can note it down in your notes. So this was bacterial endocarditis, and there are some other microorganisms also which can cause endocarditis. Those are included in other infective types. So they are tuberculous, syphilitic, fungal, viral and rickettsial. Actually first one is tuberculous. It is also a type of bacteria, but due to some special features it is mentioned separately. But it is not that it is not because it is mentioned in other types, it is also bacterial, but due to some special features it is mentioned separately. Then syphilitic endocarditis, that is involvement of endocardium in syphilis infection. Then fungal, it is rare than bacterial. Then viral is actually not seen normally, it is just seen in experimental conditions. And then another rare form is rickettsial endocarditis. So that this is it for endocarditis. We have seen all 5 major types of endocarditis, and if you have any doubts regarding this, you can ask in the comment section, and we will see you in next lecture. Till then, bye bye.